Dr. Toby Eyre is a consultant haematologist at Oxford University Hospitals, NHS Foundation Trust, specialising in the management of lymphoid malignancies. He's a national expert in the management of patients with lymphoma and CLL. He's an investigator on a number of national trials and has published nearly 70 peer-reviewed articles on lymphoma and CLL and has presented regularly at national and international conferences. Special interest to us are your trials that you're doing. So I know you're going to talk about all aspects of CLL, but we'll come back to you about your trials later. Just also to say, people, if you've got any questions for Dr. Eyre, please put them on the Q&A. We'll get them together, and we've got a long time for questions at the end.
Thanks for the invitation today. What I was going to hopefully do is just sort of run over kind of a few real sort of summary slides as to where we're up to with CLL treatment in 2022. So kind of a contemporary look at sort of how I might treat a new patient kind of who comes in with a new diagnosis today. Now, I appreciate lots of you have obviously had CLL a long time. Some of you may be more recently diagnosed. And hello to everybody I know, by the way, on the participant list. I had a little look down and some familiar names, I should say, came up. So yeah, hi everybody to whom I've seen in clinic. So I was just going to give a kind of overview initially just of obviously the diagnosis, how we make it briefly, and then move kind of fairly quickly on to kind of how we treat it now in 2022. And then that will segue into a bit about kind of sort of where the kind of so-called unmet need lies in CLL, or where the kind of new developments are kind of are coming through. So as many of you will know, CLL is a diagnosis that's often made kind of people who are asymptomatic. Actually, a lot of people have a blood count for a completely unrelated reason. That's kind of probably the commonest scenario that occurs in clinic, and so. Of course, that then leads to, often a kind of difficult start with people being kind of sort of called up out the blue, being told they've got abnormal bloods. And I'm sure this kind of resonate with lots of people, having to see their general practitioner who, will probably know a variable amount about CLL, understandably. And then, of course, it's important that that patients are given, information as quickly as possible and see somebody who sort of can tell them what their blood counts mean and what it might mean for the future, etc., and have that discussion. So that's the commonest presentation. The way we diagnose it is we do a test called flow cytometry, where in the laboratory we're effectively looking at some of the proteins that are expressed on a raised lymphocyte count level, because there are a number of different disorders that kind of can present in similar type ways. And you look for a series of kind of markers on the cell surface of the CLL cells, which kind of sort of tell you it's CLL. And there's a historical scoring system that's been used for actually many decades now that kind of has stood the test of time there. And so people who have a high score in terms of kind of fulfilling a lot of these kind of protein markers on the cell surface, the diagnosis of CLL is pretty kind of secure and easy to make. It's harder to make with people with lower scores because you need to exclude a couple of other kind of sort of similar conditions. The key one being a condition called mantle cell lymphoma, which behaves in a kind of fairly different way actually to CLL. So that's kind of one of the key things initially. And then obviously when we see people for the first time, Mark's already sort of alluded to this, but a key thing is, of course, working out how much disease an individual has, whether they need treatment or not. Obviously, most people don't need treatment initially. There are a proportion, of course, that do, but most people are observed for quite a period of time. And in Oxford at the moment, we've got a study called the Oxplode study, where we're enrolling people who've been diagnosed with CLL that don't need treatment, trying to get a better understanding of people's baseline genetic kind of profile in their CLL and seeing how that predicts for something called time to first treatment. So, your time from observation when you're first being observed through to the time at which your doctor tells you now's probably the time to start some treatment. And we go through at that baseline kind of initial assessment a number of factors, including kind of, I suppose, the diagnosis, the nature and the behavior of it, try to sort of allay some of the fears around the language of the disease, because I think that's one of the problems initially, that actually people need to overcome, the wording behind well, actually, all three words actually in CLL are problematic for different reasons. Chronic, of course, most people kind of assume is bad. It doesn't necessarily, of course, mean that, but I think that's probably a very reasonable sort of layman's assessment of it. Lymphocytic is just a word that just means nothing to a layman, and so that needs breaking down and understanding. And then finally, leukemia, of course, is a hugely emotive word, and nearly everybody before they've been diagnosed with CLL, or unless they've happened to have had a close friend or relative diagnosed with it, sort of thinks of kind of Great Ormond Street and young children walking around with no hair when they think of the word leukemia, which is, you know, not always the most kind of helpful analogy, because I think people just associate the word very emotively with very bad things happening. Now, I think that's a kind of broad, obviously a kind of very broad statement. It might not be true for everybody, but certainly a very common experience in my view, that you sort of have to break this all down and remove some of the remove some of the kind of either preconceptions or misunderstandings around the terminology, which, you know, may not have been explained particularly well up until that point, or variably well. And then, of course, as Mark has alluded to, we go into all the kind of key supportive care bits, which at the moment is about vaccinations. It's about infection risk, about skin care, about kind of sort of generally sort of living well and understanding the kind of psychology behind the initial diagnosis. And certainly in my experience, it takes people many months to kind of, I suppose, you know, adjust to a new diagnosis of CLL, sometimes much longer. And I tend to tell people that that's common and you're not alone, and that's a normal thing. And in, you know, in 6 months to a year's time, you'll probably feel kind of better about it, but that you'll be entering sort of a new phase of your life in that regard. But I also tell people now, certainly, that they will live for almost certainly many, many years with the condition, either with or without needing treatment. And that treatments have, as I will show you in a minute, advanced to such a degree that, you know, there's growing confidence amongst, you know, the likes of myself around the country that the vast majority of people will be able to control their disease either with or without treatment for, you know, decades. So things have really changed in CLL, and, you know, amazingly so. And sort of long may that continue. But of course, you know, all the aspects around supportive care, etc., remain important and always will do, actually, kind of moving forward. So that's a kind of brief summary of both how we diagnose the condition and sort of the initial type of aspects to the initial consultations that I'm sure many of you will have experienced. What I'm going to do now is just sort of briefly run through where we're up to. Now, I'm not going to bombard you with data, you'll be probably pleased to know, but I'm just going to give you sort of an overview of the kind of treatment paradigm and how it's shifted over recent years. So this is an example slide of a class of drug called Btk inhibitors that, you know, many of you, I'm sure, will be familiar with. There have been clinical trials comparing this class of drug, so-called a covalent Btk inhibitor. So ibrutinib and acalabrutinib are the two examples on this slide. They've been studied with or without a CD20 antibody. So CD20 is one of these proteins you find on the cell surface of the CLL cells, and there have been antibody drugs, so rituximab, obinutuzumab. You can see here on the Illuminate study in the bottom left-hand corner. These are drugs that have been developed and actually are used in CLL a fair bit, and a number of different B-cell cancers, because the CD20 is targeted on the B cells. And you can see here that a range of studies have been performed comparing these new drugs. So acalabrutinib, ibrutinib is the first generation Btk inhibitor, and acalabrutinib is a second generation Btk inhibitor, compared to chemotherapy, effectively. So immunochemotherapy means a chemotherapy drug or combination of drugs in combination with an antibody. And the top left-hand side one, so here, this is ibrutinib versus chlorambucil, which is a kind of one of the oldest chemotherapy drugs, which is used in older patients, or historically has been used in older patients. In the middle here, this is a study of ibrutinib versus bendamustine rituximab. So a sort of middle ground chemotherapy regime that sits somewhere between chlorambucil and FCR. And then bottom right here is ibrutinib rituximab versus FCR. And in all of these studies, ibrutinib was superior in terms of the primary endpoint of the study, which was progression-free survival, which basically effectively is time from the start of the treatment until the CLL reoccurs. A study here with acalabrutinib has also been shown to improve outcomes compared to chemotherapy as well. So, and then the bottom left one, again, a similar study compared to chlorambucil-based chemotherapy. So all of these studies have basically shown that if you replace in the frontline treatment setting treatment with a BTK inhibitor, so BTK is just a protein that's found in the growth pathway of the CLL cells that has been targeted and very effectively targeted in CLL, in mantle cell lymphoma, in a number of other B-cell cancers. You can improve people's progression-free survival. So time in remission, first time around. Now, for a variety of reasons, ibrutinib wasn't actually NICE approved in the frontline setting, and actually still isn't approved for all patients or all patients over 65, for example, based on these trials. I don't have time to go into kind of all the reasons for that, but it's been used, as many of you will know, in the FLAIR trial, which has enrolled in the UK for the last few years. But acalabrutinib, so second generation BTK inhibitor, is NICE approved, and is NICE approved as monotherapy for generally for people over 65, or for those who aren't considered kind of suitable for kind of more intensive chemotherapy. Based on this study, the ELEVATE treatment naive clinical trial. And actually, there's been a lot of usage of acalabrutinib in the UK over recent years. The overall point I want to kind of make, though, is that chemotherapy we've really shifted away from chemotherapy based on these trials, and also some other ones I'll show you in a minute. And one of the frontline options, therefore, in a lot of patients is acalabrutinib, and it is being used in a fair number of people across the UK at present. So those are BTK inhibitors. The other kind of key class of drug, which I just wanted to kind of highlight, which again many of you will know about already, is a drug called Venetoclax. So this is a BCL2 inhibitor. This is different. So BCL2 is a very important, the kind of medical phrase for it is anti-apoptotic pathway. So basically it's a protein which stops cells dying. And if you inhibit a protein which stops cells dying, it's kind of like double negative there, but if you do that, then actually cells will die. And actually this is a really potent part of the CLL pathway, because CLL cells are extremely good at not dying. They sit there and they just kind of linger for a long, long time. And it just so happened in the early studies of this drug, or this class of drug, the early development of these classes of drug really struck gold, because they were extraordinarily potent. And actually their targeting BCL2 was just found to be extremely effective. And this was first studied in people, actually a slightly different version, slightly different drug to Venetoclax. But it was so effective that actually a couple of patients died of tumor lysis syndrome. So they died because their CLL cells were breaking down so rapidly that all the salts in their blood were causing major issues with their kidneys and so forth. So the early studies were then stopped. They were amended, and there was a very careful, what we call ramp-up phase of the dosing, which many of you no doubt will be probably more familiar than I am, because you've kind of sort of lived through it. But because of that, the way Venetoclax is given is it's given very gradually over a period of time. So you increase the dose from 1/20th of the actual dose, actual final dose, over a 5-week period. Now, this drug was initially developed in people who'd had a number of lines of treatment before, and as is natural with any successful drug, the company develop studies that bring the drug further forward in the kind of treatment pathway. And I'm just showing you two examples of studies which have produced results over recent years, which have led to the frontline use of venetoclax in combination with a drug called obinutuzumab, so a CD20 antibody. The CLL14 study is the kind of the study which has been probably the study that's changed practice over recent years the most in the UK with this class of drug, because this is a study that compared venetoclax in combination with obinutuzumab. So you can see here what you do is you give the CD20 antibody first, and then you do this dose ramp up, and then you have the treatment combination together for 6 months or so, and then venetoclax by itself for 6 months. And that's compared with chemotherapy, so the kind of traditional chemotherapy plus an antibody that we've used over recent years. So if you had come to my clinic 2016 and you were, say, 78 and had a couple of medical other problems, this is what you would have received. But now you probably receive this or acalabrutinib. And this is the result of this study. This is a progression-free survival curve, basically showing that more people are in remission as time goes by. So you can see here at, say, 3 or 4 years follow-up, 70 to 80% of people here with venetoclax patients are still in remission, compared to only, say, 30% or so with chlorambucil obinutuzumab. So now, take my word, that's quite a remarkable difference in terms of progression-free survival, and that's led to the frontline use of venetoclax obinutuzumab. Now, this study was initially designed for kind of older patients, so people who wouldn't necessarily have been fit for bendamustine treatment or FCR treatment. But there has been a recent study read out for the first time called the CLL13 study, which is sort of asking a similar question. This is a slightly complex design, but the bottom line here, I just focus on the top line. So this randomization is FCR or bendamustine, so kind of more kind of, I suppose, punchy chemotherapy, if you to put it one way, certainly stronger. And one of the randomizations here is this same regime, so venetoclax versus obinutuzumab. So I just want you to focus on those two, because actually we don't have results of all the other bits yet. And this is actually a very early readout of this study. And one of the results is looking at something called minimal residual disease, where you actually look to see how many cells there are in like 1,000 cells, or 10,000 cells, or 1 million cells that are CLL related. The bottom line is that the non-chemotherapy treatment, so the venetoclax plus the obinutuzumab here, provides much higher levels of clearance of the blood according to MRD than the chemotherapy. That's very reassuring early data, because this is the first time these combinations have been sort of these combinations have been studied against each other. Certainly, this early data suggests that that the combination is potentially very effective in sort of younger people as well, which is important. So these changes have already happened in the last kind of 3-4 years, actually. So now in the UK we have frontline, and both acalabrutinib and venetoclax obinutuzumab have been through NICE and are available. We can use venetoclax obinutuzumab as kind of baseline commissioning in older patients, and in younger patients it's in something called the CDF, so the Cancer Drugs Fund, and with the hope that will move to formal kind of full NICE approval at some point. But the point is pretty much for every patient in the UK now, we have a non-chemotherapy based strategy that we can offer people first time around, which is great, and it's a big change over recent years. So here are the kind of two options, and no doubt, kind of when you've perhaps been, in your clinics and talking to to your physicians, you may have discussed this very kind of principle, because effectively now we have two kind of classes of drug, which are both very, very effective, work for many years, and work with completely sort of independent and different mechanisms from each other. And so therefore there's kind of sort of a choice, and there are theoretical pros and cons of either. And one of the kind of key differences here is venetoclax and obinutuzumab are very good at kind of clearing your blood and your bone marrow, and so therefore can be given as a so-called fixed duration treatment. So you'll have seen on that slide before, you give the combination for 6 months and then venetoclax for another 6 months. So it's a 12-month fixed duration treatment. Compare that to acalabrutinib, which no doubt some of you will be taking at the moment. That drug you continue almost like a blood pressure tablet year after year after year for as long as it works for. And because it's used in the frontline setting, and because the drug works very nicely, actually that may mean 6, 7, 8, 9 plus years taking acalabrutinib. Now, the advantages of acalabrutinib is the initiation of the drug is easier. You kind of basically give somebody a tablet, and obviously after going through the kind of consent process and talking about theoretical adverse events, etc., they are easier to start than the venetoclax obinutuzumab, which requires the ramp up phase, and often via day treatment units, sometimes even requiring occasional hospitalization, and requires a fair bit of blood test monitoring in the first 6 weeks or so. It does get easier, as many of you will know who've been through it. You know, certainly the second 6 months is easier than the first 6 months, and beyond the first 6 weeks, it does become easier. But there's certainly a fair bit of monitoring and a fair number of hospital visits, etc., during that period of time. So pros and cons of the two options. Of course, one of the key questions is which is optimal, which should we use first? Well, the question to that hasn't been answered, and is the I suppose the subject of ongoing frontline clinical trials internationally. And there's a big German CLL study looking at that kind of very question. And I suppose the other big question is, well, does it matter which order you use them in terms of, do you affect the sort of do you affect the effectiveness of another class of drug if you use them in a certain order? Now, because ibrutinib was the first drug that came along, and then sort of venetoclax came along about 4 years, 3-4 years later, effectively, then most of the clinical trial data that we have really is looking at venetoclax after ibrutinib or after a drug called idelalisib, which it has been used historically in the UK, but isn't used a huge amount now. And the clinical trials that we have are kind of listed here. This one here shows that it actually venetoclax does work pretty well after ibrutinib, after previous ibrutinib, and a lot of these patients had prior chemotherapy prior to that. But there are no kind of randomized clinical trials or prospective clinical trials that have enrolled that actually have studied Btk inhibitors, so ibrutinib, acalabrutinib, after venetoclax-based treatment. So we're somewhat more reliant on so-called kind of real-world data sets of basically clinicians like myself all kind of clubbing together to pull together data to get an idea as to whether these drugs work in that order, for example, because the clinical trials just haven't been done, and quite honestly, there's very little appetite to kind of sort of prove that they're effective in the other direction. Is quite a difficult study to do. But nonetheless, we've pretty much got evidence, that as good a evidence as I think we're going to get, that ibrutinib and acalabrutinib do work. So have really good response rates after people have had prior venetoclax. And this again is without getting to loads of detail, this again is in a really quite a, I suppose, heavily treated group of patients. So effectively now, if I treated somebody kind of 2022 starting from scratch, you'd have one of these classes of drug, followed then by probably the other class of drug at a subsequent line of therapy. Now, if you kind of did a sort of back of the envelope calculation on how long these drugs kind of work for, each of them, you're probably looking at somewhere between 10 to 15 years worth of remission simply with these two classes of drug in terms of kind of disease control. So, and that really compares very favorably with sort of historically what people could expect from, say, FCR or chlorambucil rituximab or whatever chemotherapy you're talking about. At the moment, you can retreat people with venetoclax. One of the things about it, of course, is you're giving it as fixed duration. So one of the advantages is, in theory, you can give people the drug again, because it doesn't necessarily mean they're kind of totally resistant to it if the CLL comes back, because you actually haven't exposed people's CLL for a long time to that drug. And so people's CLL doesn't necessarily become sort of resistant to it. And so retreatment at a later time point is an option. And then beyond those two classes of drug, if you have the kind of rare situation where you have, particularly young person, maybe with very kind of high risk CLL genetics, who have had both of these classes of drug, you're then into a kind of realm of, a realm of the kind of treatment where we're not entirely certain sort of what the best treatment is. And it's an area where people are investigating new treatments. And I'll come on to that just after this slide. So this, I think, is my final slide. This is the UK CLL British Society of Haematology guidelines, which have just been published recently, which I was involved in. And it essentially just goes through kind of exactly what I've sort of just talked through in terms of the treatment algorithm. And the bottom line here is that patients will effectively run through those two classes of drugs, either frontline or second line. And then in the third line treatment setting, it's very dependent on what people have had before, whether they've had problems with, for example, intolerance to a class of drugs. So, for example, there have been issues, certainly historically, with people having problems with ibrutinib intolerance, and acalabrutinib is a better tolerated BTK inhibitor, and is often effective and actually better tolerated in people who maybe stopped ibrutinib for reasons such as toxicity. And there are a variety of potential problems that ibrutinib can cause. So, for example, here you might, in the third line setting, if you used ibrutinib, in a trial or for some reason in the frontline or relapse setting, you could in theory use acalabrutinib. If you haven't, you could in theory retreat people with venetoclax, as I mentioned a minute ago. But then as I say, if you genuinely had a situation where somebody had got through both of those treatment lines, then you're very much into the realm of clinical trials. And what I wanted to do is maybe just spend a kind of couple of minutes, and then perhaps the questions will kind of maybe be able to touch on this a bit more. Just a couple of minutes just on clinical studies in this particular space. There are a number ongoing, certainly a number of classes of drugs ongoing in people who have been exposed to both of these classes of drugs. You can imagine that because they're both very effective and they work for many, many years, it's actually quite hard in some respects to find patients to study new drugs because lots of people are still, thankfully still on those drugs and actually doing pretty well. The main class, I think one of the main classes of drugs that's been developed over recent times are the so-called non-covalent BTK inhibitors, and they certainly seem to be the sort of the drug that has maybe made the most headway over recent times. So one of the things about ibrutinib, acalabrutinib, also a drug called zanubrutinib I haven't talked about, but these drugs, they bind, I'm not going to get too technical, but they bind covalently to BTK. And basically you can get a particular resistance mechanism in the pocket where the drug actually binds to the protein. And these newer drugs actually don't rely on that same binding mechanism. And so they are effective in people who have become resistant to ibrutinib or acalabrutinib because of this BTK binding mutation problem. and they're oral tablets. The drug that's in kind of, I suppose, most rapid development that probably you have heard about is a drug called LOXO 305, or pirtobrutinib is its new name. Got to kind of practice that one in the shower, but pirtobrutinib it's been called, and that drug looks to be very effective in that kind of setting. So response rates of 70+%, and looks to be a very well tolerated drug. And I've used a fair amount of it in clinical trials, and it certainly comes with my recommendation. It's been highly effective and has worked very well in people who have had extraordinarily high risk of CLL relapse based on their prior history, etc. And actually, that study continued to run throughout the pandemic. It was quite unusual. There was most studies kind of stopped for a period of time, whereas this one kept running. And I received referrals from actually all around the south of the country for this clinical trial, and it was very effective. Now, this drug actually is being developed further in CLL in random. What often companies have to do is they have to then obviously move the drug into randomized trials to kind of try and improve on the current standard of care. And it's being studied in a number of randomized trials at the moment, kind of slightly further up the treatment pathway. A couple of other kind of briefly, a couple of other classes of drugs which are in development. So I should just say, for completeness, there are other companies developing non-covalent BTK inhibitors as well, perhaps just a little bit further behind in terms of development. But there are other studies running in the UK that are just kind of enrolling, starting to enroll, where non-covalent BTK inhibitors are being used. And then a couple of final things. CAR T-cell treatment is in development in CLL. It's been a bit slower than other treatments. So just very briefly on CAR T-cell treatment. So this is a kind of fairly clever technology where a person's own T-cells are removed, so-called apheresed or removed from their body, and then manufactured with a clever bit of technology to basically attach an antibody onto the patient's own T cells, and then they're reinfused to the patient. And so what then happens is those T cells then kind of sort of know where to go in terms of attacking the antibody, the place where the antibody is added onto that cell. So if you added in a CD20 or a CD19 antibody onto the T cell, what that does is it goes and finds that protein in someone's body and brings very close to it your own immune system T cells, which then start to kind of sort of attack those cells. And so that's how CAR T cells work. They've been very effective in a couple of aggressive types of lymphoma, not so much in CLL, partly because when CLL people go through lots of lines of treatment, their T cells don't actually tend to work quite so well. And that's been a challenge in terms of developing CAR T cell treatment in CLL. But nonetheless, it is still under development. There's a new class of drugs called bispecific antibodies. So this is kind of similar in terms of concept to CAR T cells, but slightly different. So this is an antibody. So it's a bit like rituximab. It's an antibody, but it targets both your own T cells by targeting something called CD3, and also targeting the cancer cells, so the CLL cells, by targeting CD20. So what you do, kind of in essence, is you bring together the tumor cells and your own immune system T cells just in a different way by having sort of a two-pronged antibody. And in theory, that could work very well. It's again being studied in fast-growing lymphomas, in low-grade lymphomas, and is in development in CLL. And we're just on the brink of opening that study in Oxford. And so that will be another interesting drug. So there's just a kind of couple, 2 or 3 examples of things in development. There are more, but for the interests of time, I will probably finish talking there. I hope that was kind of interest, and I'm happy to hopefully we'll go through some questions.